Anderson Cancer Center, Professor of Department of Leukemia and Cancer Research, Section of Chief, Chronic Lymphocytic Leukemia, Department of Leukemia at MD Anderson Cancer Center, Houston. He did his postgraduate training, internship, and residency at Duke University from 93 to 96, and subspecialty fellowship, Hematology Oncology, University of California, San Diego, 96 until 99. And I saw his CV. There's a lot of things, but I summarize that he has a lot of honors and awards and many research publication in leukemia field, especially in chronic lymphocytic leukemia. And he will update us in chronic lymphocytic leukemia management. And welcome, Dr. William. The floor is open for you.
Thank you, and thank you to the meeting organizers for this invitation to come and speak to you about chronic lymphocytic leukemia. Can you hear me okay? Are you able to hear me? Okay.
Yes, yes.
All right, so I'm going to be reviewing chronic lymphocytic leukemia. I have a lot of slides. I was going to update you on what was presented at ASH in December. I first want to show you some background slides and sort of set the stage in terms of standards of care treatment for CLL, patients with CLL. Treatment has evolved over the many years shown on this slide, starting with chemotherapy and chemoimmunotherapy. And over the last 10 years or so, we have moved into the era of targeted therapy. Targeted therapy has been very beneficial for our patients in that targeted therapy is very effective at treating the disease, at controlling the disease. It's better tolerated by patients who are older. That's the majority of patients with CLL. And it has allowed us to talk again about deep remissions and getting patients into an MRD negative state, including older patients, with combinations of targeted therapy. So there's been a big evolution in treatment, and we're really now in the era of targeted therapy and talking about combinations of targeted agents. And I think we're probably on the cusp or verge of developing curative strategies for patients, a large percentage of our patients with CLL. This slide just summarizes that evolution in treatment. And this slide summarizes the intracellular signaling molecules that have been targeted with small molecules for targeted therapy. Most notably have been BTK and drugs that have been developed as BTK inhibitors, Bruton's tyrosine kinase. That is a downstream signaling molecule from the B-cell signaling receptor. Also PI3 kinase has been identified, and I'll talk a little bit about a new drug that's been reported on recently, umbralisib, which is a PI3 kinase inhibitor. And then all the way over on the right side of the slide, you can see that BCL2 and BCL2 family members have been targeted, particularly BCL2 itself, as targeted therapy for treatment of patients with CLL. This slide summarizes the agents that we have in the US that are approved. I'm sure you have many of these agents available, and hopefully you're moving from chemotherapy-based treatment into targeted therapy because of the benefits that we're seeing for our patients, and that I'll review for you in the next several slides in terms of what has become standard of care for our patients with CLL. There are features of the disease that we have talked about for a long time that characterize an individual patient's disease that we evaluate for patients, particularly those who need treatment. I usually will test for these things when patients are newly diagnosed because I like to know the patient's characteristics, disease characteristics, and what to expect from the patient's disease. That is, is a patient likely to eventually need treatment? But these features are particularly important in terms of selecting treatment. We'll talk a little bit more about them. Those are highlighted here. FISH, we need to know if a patient has 17p deletion or not. That's the most important chromosome abnormality that we follow. There are others that we've talked a lot about over the years, but this is really the most clinically meaningful abnormality that we identify with FISH. The gene located at 17p is TP53, and we need to know the mutation status of TP53 because that is a very important prognostic feature and also does help us direct treatment. Next, and those can change. Patients can acquire those abnormalities with time. So rechecking those is important in patients who need a treatment change or who have been in remission and have relapsed, and we're talking about retreating them with a new treatment. IGHV mutation status is an important feature. That's important in terms of selecting treatment, particularly for patients who are younger and can potentially tolerate chemoimmunotherapy, particularly FCR. For the most part, though, most of the patients, it's less helpful because it doesn't really change treatment, particularly for patients, older patients, patients over 65 who don't necessarily, or who aren't able to tolerate FCR. There are other prognostic factors, and some of them I'll talk about in some of the newer data that are potentially helpful in predicting outcomes for patients going on a BTK inhibitor. Those are LDH and beta-2 microglobulin. So this slide sort of summarizes a discussion about goals of care and what we talk about and think about in terms of goals of care for our patients who are going on treatment. Indications for treatment have not changed, so patients are monitored with observation until they have an indication for treatment. Those indications are disease-related symptoms like night sweats and fatigue, or progressive anemia or progressive thrombocytopenia. Those indications for treatment haven't changed, and we're still using the same indications that we've used historically. And if patients don't meet those, they should be continued on observation, even if they have a high-risk feature like 17p deletion or mutated TP53. So for first-line therapy, goals of treatment are important, and they basically fall into two categories. We can achieve long-term disease management with a BTK inhibitor-based treatment, or the other approach is a deep remission and trying to get patients off treatment. Historically, we've done that with chemotherapy. Now we can do that with targeted therapy, with venetoclax-based therapy. And so considering what those options are, having a discussion with a patient, considering the outcomes are important in terms of selecting first treatment for your patients. And we'll talk a little bit about the data in the next several slides. And that's for first-line therapy. For relapse disease, long-term management, I think, is the most important issue. So you want to be careful and thoughtful about sequencing and leaving treatment options open for patients. And long-term disease control is the goal and strategy for treatment for relapsed disease. I mentioned already, these are the three factors that I need to know for patients who are going on treatment: 17p deletion status, mutated TP53 status, and IGHV mutation status, particularly for younger patients. And as I mentioned, the IGHV mutation status doesn't change, but patients can acquire high-risk chromosome abnormalities like 17p deletion and mutated TP53. There have been several phase 3 randomized trials that have been reported over the recent couple years that have clearly demonstrated improved outcomes with targeted therapy over chemoimmunotherapy. And those are summarized here, and I'm not going to go through the details of each of them. The 5 trials highlighted here where targeted therapy, particularly BTK-based therapy, is compared with chemoimmunotherapy. And the chemoimmunotherapy evaluated here spans the intensity from chlorambucil obinutuzumab to intensive chemoimmunotherapy like FCR. All of those trials showed improved outcomes with targeted therapy, with BTK inhibitor-based therapy. There is some controversy about additional benefit of CD20 antibody with targeted therapy, with BTK inhibitor-based therapy. We do not routinely use the CD20 antibody with BTK inhibitor-based therapy in the frontline setting or the relapsed setting, because we're lacking compelling data showing benefit with the addition of the CD20 antibody. And in these trials, BTK inhibitor-based therapy was continuous until progression. And so it's long-term disease control with these strategies, with BTK inhibitor-based therapy. Ibrutinib being the first drug evaluated, acalabrutinib being the more recent drug. And we'll talk about a little bit about the differences between those. And both are now approved in the US. I don't know if you have those available in Jordan for frontline and for relapsed disease. And then CLL14 is a trial, and I'll show you some updated data with regard to CLL14. With venetoclax plus obinutuzumab, clearly demonstrating improved outcomes with venetoclax-based therapy over chlorambucil obinutuzumab in the frontline setting for more frail patients. This strategy is a fixed duration treatment, 1 year of venetoclax, remission, off treatment, and then observation in remission with venetoclax-based therapy. And that's again in contrast with BTK inhibitor-based therapy. This slide summarizes my preferences for first-line therapy. And it sort of categorizes patients as those with 17p deletion or mutated TP53. I like durable disease control with continuous treatment for those patients, so my preference is a BTK inhibitor. My preference is acalabrutinib in that situation for that patient population. Because I think those patients, even if you can get them in remission, I worry about them in remission off treatment with a 17p deletion or mutated TP53. Their remission is expected to be shorter, and they're at higher risk for shorter progression-free survival. So I like continuous treatment for that particular group. For the other patients, either the older, more frail patients, even the younger fit patients, my preference is with fixed duration treatment. Achieve a remission, get them in remission. The remissions we're seeing with targeted therapy are very deep, and you can get patients off treatment for an extended period of time. And so my preference is fixed duration treatment with a BCL2 inhibitor plus CD20 antibody, obinutuzumab. Regardless of their mutation status. We do still talk about FCR-based treatment for the patients with a mutated V gene, so that at the very bottom is a standard of care for younger fit patients with a mutated V gene, because about 50% of them are potentially cured of their disease with FCR-based treatment. So I just want to set the stage in terms of expectations for outcomes with targeted therapy based on the data that's been published. This is a slide that summarizes outcomes with RESONATE-2. This is ibrutinib versus chlorambucil. In the gold curve, you can see superior progression-free survival with ibrutinib-based therapy compared to chlorambucil in this analysis. And a longer follow-up here segregates patients by whether or not they have an 11q deletion on the left, and on the right by IGHV mutation status. You can see outcomes are similar whether or not patients have an 11q deletion on the left, and that's in the purple curve versus the gold curve for those patients treated with ibrutinib-based therapy. And on the right, the outcomes are similar for patients whether or not they have a mutated or unmutated immunoglobulin gene. Again, comparing the gold and the purple curves at the top. Both categories of patients do well. With ibrutinib-based therapy, 11q deletion doesn't appear to be a high-risk feature, nor does unmutated IGHV mutation status. And these curves go out to 5 years, so you can see an extremely good progression-free survival with ibrutinib monotherapy continuous treatment for patients with 11q and patients with an unmutated immunoglobulin gene. 17p deletion does remain a high-risk feature, and this is data from the NCI group showing outcomes, progression-free survival on the left and overall survival on the right among this group of patients, all of whom had a 17p deletion and were treated with ibrutinib-based therapy. Among the 17p deletion, it does appear that unmutated V gene is a higher risk feature. That's the patients in the red curve, both in terms of progression-free survival, perhaps in terms of overall survival, but their outcomes are inferior compared to the non-17p deleted patients treated with ibrutinib. They have a shorter progression-free survival, and you can see at 6 years, 61% is the progression-free survival for this particular cohort of patients. So we will still worry about 17p deletion, even in those patients receiving ibrutinib. My preference in the frontline setting and the relapse setting is continuous treatment with a BTK inhibitor. This is data from the RESONATE trial and shows long-term outcomes with ibrutinib in the relapsed setting. On the left, progression-free survival, on the right, overall survival. And you can see the median progression-free survival in the relapsed setting with ibrutinib monotherapy continuous treatment. Median is 44 months. Overall survival on the right, you can see, is 67 months. Those are extremely good outcomes for a relapsed cohort of patients, but requires continuous treatment with ibrutinib. In the relapse setting, 17p deletion continues to be a high-risk feature with ibrutinib-based therapy, but the outcomes are much better than they ever would have been with a chemoimmunotherapy-based treatment. So that's the red curve, and you can see a median progression-free survival of about 2 years with ibrutinib-based therapy in this setting. The NCI group published work in terms of what are the risk features or prognostic factors for patients receiving ibrutinib-based therapy. And those are summarized here. There are 4 factors that we evaluate that categorize patients in terms of their risk for progression, free survival, and shorter overall survival. They're highlighted here whether or not patients have been previously treated, whether or not they have a 17p or mutated TP53. High beta-2M is a high-risk feature independent among this group, and also elevated LDH. And the progression-free survival and overall survival curves are shown here. So these data confirm what we have been seeing in terms of other trials. And I think the 17p are the main patients that we need to focus on and follow, including with targeted therapy. We have very much better outcomes with targeted therapy with that subgroup, but they still remain a high-risk group. So the next, and that sort of summarizes what I just went through, where we're at with targeted therapy in the US. And I'm going to highlight some of the studies that were shown at ASH, and those are summarized here. So venetoclax-based therapy, there was an update for CLL14, which is a 4-year update, and then a 5-year update for the Murano trial. The Murano trial was a relapsed trial of venetoclax plus rituximab versus bendamustine rituximab. And you'll see the very good outcomes, long-term outcomes for that study. And then there are combination targeted trials. One is the Captivate study that I presented at ASH, and then the other, and that's in the frontline setting, the other is a Clarity study that the British group reported. There's a phase 3 randomized trial with the PI3 kinase inhibitor, which I mentioned, which is umbralisib. That's the Unity trial I'm going to review. And then there are newer agents in development. LOXO305 is a reversible inhibitor of BTK. That's showing very promising activity, which with extremely good tolerability. And then the CAR T-cell treatment. So first off is the CLL14 update. This was a frontline randomized trial for frail patients, venetoclax obinutuzumab, venetoclax given for a year versus chlorambucil obinutuzumab, chlorambucil given for a year. 4-year progression-free survival, you can see here, 74% for venetoclax-based treatment, 35% for the chlorambucil. So long-term outcomes, very good with venetoclax-based therapy, 1 year of treatment, and subsequent durable remissions with a high rate of undetectable MRD. for the venetoclax-based treatment. No difference in overall survival at this point. This slide summarizes and highlights the high rate of undetectable MRD in blood at end of treatment. You can see about 75% of patients were undetectable when using the 10 to the minus fourth level, all the way over on the left with venetoclax-based therapy, which was much better than what was achieved with chlorambucil-based treatment. So that is highlighted by those green bars in the graph. Patients did improve with the continued monotherapy of venetoclax between the end of combination and the end of 1 year treatment. That's summarized here. And what the longer-term follow-up with this trial evaluated was also relapse, and who are those patients likely to relapse, and what does relapse look like in these individuals. So this, the German group evaluated the kinetics of MRD relapse and sort of plotted that out for patients. And this is a complicated slide, but in essence, it shows that the kinetics of MRD relapse is more rapid for those patients who received chlorambucil-based treatment compared to venetoclax-based treatment. So one of the questions that arises from this data is whether or not you select for high-risk clones or even induce high-risk clones with exposure to chlorambucil, where you don't see that selection with venetoclax-based therapy. And the kinetics, rapid kinetics of relapse were associated with other higher risk features that we're aware of, including among those patients who receive venetoclax-based therapy, things like unmutated V gene, 17p deletion, etc. So very good outcomes with frontline venetoclax-based therapy, and the long-term follow-up continue for that trial. The next trial that was updated was the Murano trial. This was a relapse trial for patients who were randomized to receive venetoclax rituximab or bendamustine rituximab, 2 years of venetoclax treatment with the first 6 cycles of rituximab included, 2 years of treatment with venetoclax with this trial in contrast to the 1 year with in the frontline study. Long-term 5-year follow-up showing extremely good outcomes. On the left, progression-free survival. On the right, overall survival with a median of 54 months. Progression-free survival with venetoclax. And you can see an improvement in overall survival in the blue curve, 81% at 6 years compared with BR at 62%. So these, I will remind you of the progression-free survival curve that I showed with Resonate, which was 54 median median progression-free survival with ibrutinib-based therapy. So this median progression-free survival is consistent with that when we do a cross-trial comparison. In my mind, the benefit of this strategy is that it's 2 years of treatment, and then patients are off treatment and in remission off treatment. They looked at correlations with outcome on the left, progression-free survival on the right, overall survival correlated with undetectable MRD status at end of treatment. Those are the patients in green. So if you can achieve a deep undetectable MRD status, patients do well, which we know from other trials. We know that from chemoimmunotherapy. That was illustrated in this trial. They also looked at kinetics of relapse. And for patients who achieved an undetectable MRD, the time to MRD relapse, the median time to MRD relapse is shown there in the middle, is 19 months. And the median time to progression from MRD relapse is about 2 years. So this gives you kind of an idea of the depth of remission and what to expect in patients in terms of the median time to relapse with regard to MRD and what you can expect for clinical relapse after that. And rapid kinetics of relapse were associated with the features, high-risk features that we know of, 17p deletion, complex karyotype, and unmutated immunoglobulin gene. And similar to CLL14, kinetics of MRD relapse was more rapid among those patients who were treated with bendamustine-based treatment compared to venetoclax-based treatment. Okay, moving on to the combination work. We did a trial here at MD Anderson. with combined ibrutinib plus venetoclax, combined targeted therapy for patients. That trial had a frontline cohort and a relapse cohort. We reported that in the New England Journal, and subsequent trials have been reported, have been conducted and are being reported, one of which is the Captivate trial. This was an international multi-center trial. Patients received 3 months of ibrutinib monotherapy for debulking and then 12 cycles of combined treatment. And the data that I presented at
thank
ASH.
you, Doctor, for this comprehensive talk. My question about the BTK inhibitors. We know that for the patient with CLL who started on BTK inhibitors, we have to continue until disease progression. My question is,
Dr. we can keep the question after the lecture, please.
Oh, I'm sorry.
Okay.
I'm sorry.
All right. So in terms of the Captivate study, the primary endpoint that was reported is that what was is highlighted in the red box. Those were patients who were undetectable MRD. They were randomized to either placebo or ibrutinib continued monotherapy. And I'll show you the curves, but the primary endpoint was 1 year disease-free survival, and that was not different between those two arms, placebo versus ibrutinib, which substantiates the approach of fixed duration treatment, depth of remission being important, and the fact that patients can come off treatment with an expectation of being off treatment for a reasonable amount of time. So it supports the concept of fixed duration treatment. I'm going to go through the data relatively expeditiously in the interest of time. 164 patients were enrolled on this study. You can see their characteristics here. There were a few patients that had high-risk features. Those are highlighted in the red box, 17p deletion or unmutated V gene. We did see improved we did see reduction in bulk of disease and reduction in the need for hospitalization with venetoclax initiation and ramp up with those first 3 months of ibrutinib monotherapy. So if you look at the right, the blue portion, 50%, 47% would have required treatment in the hospital with venetoclax initiation. That number went down to 18% with the 3 cycles of ibrutinib monotherapy prior to venetoclax initiation. A high rate of undetectable MRD in blood and bone marrow, that's summarized here. 75% MRD undetectable and 72% after 12 cycles of combined treatment. And then this is how patients' characteristics sorted out among their randomized arms. So 86 patients were randomized to either placebo or ibrutinib, 63 to ibrutinib continued monotherapy versus combined treatment. That was for patients who were still with detectable MRD. This is the disease-free survival curve on the right. At 1 year, you can see there's no difference in those patients who were undetectable MRD and were randomized to either ibrutinib continued monotherapy versus placebo. Again, substantiating this concept of fixed duration treatment and time off treatment. And this is the progression-free survival for all the patients combined. Now, the patients who continued either ibrutinib monotherapy or continued combined treatment are summarized here. These are patients who were MRD positive at randomization, and you can see in the hatched portions an improvement in undetectable MRD status with continued ibrutinib venetoclax compared with ibrutinib monotherapy continuation. So to me, this sort of suggests improved continued benefit with continued combined treatment. And we still struggle with the concept of, is 12 cycles a sufficient amount if patients are still MRD positive at the end of the 12 cycles? Our own trial was designed for 24 cycles of combined treatment. We have extended that now to 36 cycles of combined treatment, particularly for patients who are still MRD positive. So that's a question that we'll be answering in follow-up. Very well tolerated treatment. I'm not going to go through details on the toxicity. There were no unexpected toxicities with this combination, no safety concerns with this combination. And the British provided an updated, Pete Hillman's group, an update of a similar combined treatment in relapsed CLL of ibrutinib plus venetoclax. And they see in a relapsed cohort, about 40% of patients become MRD undetectable after 12 months of combined therapy in the bone marrow. And they also see continued improved responses with continued therapy beyond the 1 year or even 2 years of combined therapy. So in the relapse setting, we also need to answer the question of optimal duration of treatment, particularly for patients who don't achieve an undetectable MRD status. And these are their MRD data, as you can see, improved responses with continued treatment. They did present some interesting information about the fact that the quicker patients are achieving undetectable MRD, the more likely they're going to be undetectable and do better. So more rapid response in kinetics of reduction of the amount of disease was correlated with a deeper remission in their analysis. And these are their progression-free and overall survival curves for this cohort of patients. The patient cohort was about 50 patients. And so this work also continues. Okay, so moving on to the next trial is the Unity trial. This is umbralisib, which is a PI3 kinase inhibitor, plus ublituximab, which is a CD20 antibody. Umbralisib has some potential benefits over idelalisib, which is a PI3 kinase inhibitor that we've had for a few years now, that does have challenging toxicities associated with it, and I think has limited its use. This was a multi-arm trial. The arms that were presented at ASH were umbralisib plus ublituximab versus chlorambucil plus obinutuzumab. And there were both frontline patients enrolled on this trial and relapsed patients. So this summarizes all of the patients. If you look at the bottom, there were 120 about randomized to treatment naive patients randomized to U2 versus chlorambucil-based treatment, and 91 previously treated patients. And what I've done is sort of separated out those two groups because I think it's important to look at them separate. So this is for the previously treated patients and shows prior treatment. And then the progression-free survival, which is a primary endpoint. And this is for the frontline cohort. You can see improved outcomes with umbralisib-based treatment in the green curve compared to chlorambucil-based treatment in terms of progression-free survival. But I will point out that the median here is about 3 years, which is shorter than has been reported and which I showed you with ibrutinib-based therapy or acalabrutinib or venetoclax-based therapy. So the outcomes with this combination are inferior, in my opinion, to other targeted therapy options, both in the frontline and in the relapse setting, but they are better than with chlorambucil-based treatment. So in the green curve, you can see umbralisib-based treatment having a median progression-free survival of about 18 months, and that being superior to chlorambucil-based treatment. In terms of safety and toxicity, my impression is that it's a bit better, umbralisib is a bit better tolerated than idelalisib. There still are some of the same toxicities that we have seen with idelalisib, such as diarrhea, etc. But those do appear to be less common than with idelalisib. So those are also summarized in this slide. Okay, moving on to LOXO 305. LOXO 305 is a reversible inhibitor of BTK, unlike the drugs that we've had available that I've talked about already, ibrutinib and acalabrutinib, and also zanubrutinib, which are the irreversible inhibitors. They also inhibit other kinases, and that's illustrated here in these kinomes. And a new drug that's been studied and is in development is LOXO-305, which is a reversible inhibitor. And you can see, in contrast to the slide I showed before, it has a very restricted kinome and much less off-target inhibition. And it does have in vitro activity against cells that have acquired a BTK mutation, which is the most commonly associated mutation, most commonly associated with resistance to the irreversible inhibitors. That's the cysteine 481. So this is a large trial, the Bruin trial, and the updated data at ASH, I'm going to just summarize, is about 140 patients evaluated for efficacy that were enrolled on phase 1, phase 2. In terms of the phase 1 activity and tolerability, there were no dose-limiting toxicities associated with the phase 1 analysis, and the selected phase 2 dose of the drug was a once-a-day 200 milligram daily dose. So this slide summarizes the toxicity for all the patients. And as I mentioned, the phase 2 dose is the 200 milligram daily dose. And the 140 patient data in terms of activity are summarized here. Most of the patients achieving partial remission. But the impressive point for me here is that those partial responders are among patients who have developed resistance to the irreversible inhibitors, as well as BCL2 inhibitors. And as you can see on the right, the response rate does improve as patients continue on treatment. So extremely well tolerated drug that has activity in refractory disease. And that's illustrated here in terms of the progression-free survival and the duration of response curves. Okay, and then finally, I wanted to highlight the CD19 CAR T work. There were 2 studies that were summarized at ASH, one by Tanya Siddiqui and one by myself. These are the Transcend study with the CD19 CAR T referred to as Lysocell that's been developed by Juno and now Bristol Myers Squibb. This trial is a phase 1 trial. There were 2 cohorts. One is the monotherapy cohort that Tanya Siddiqui presented, and the other is a combined cohort with ibrutinib, because other groups have reported potentially ibrutinib improving the tolerability of the CAR T cells, as well as improving the activity and efficacy of CAR T. So that is a trial, that is a cohort that I reported where patients receive ibrutinib combined with Lysocell. So first I'm going to review the monotherapy update. This data has been presented previously but was updated in terms of the longer term follow-up. 23 relapsed or refractory patients, 11 of them were refractory to targeted therapy, venetoclax and or a BTK inhibitor. I highlighted in red the incidence of grade 3 cytokine release syndrome or neurotoxicity, and you can see that it's a less than 10% for cytokine release, less than about a quarter of the patients in terms of the neurotoxicity, that being grade 3 or higher with the monotherapy strategy among these 23 patients. And there were durable responses, and those are reported here in this figure. So 82% was the overall response rate, and the responses were rapid, and there was a high percentage of patients achieving undetectable MRD. I think that was summarized also in this slide, the rate of undetectable MRD, 15 patients. And those responses were durable, and similar rate of response was seen among those patients with refractory disease compared to those who were not refractory to targeted therapy. And then the combo cohort were 19 patients. Some of those patients also had refractory disease, and this summarizes the grade 3 or higher CRS and neurotoxicity. Again, a low, in my opinion, a low rate of grade 3 or higher CRS of 5%, and 16% were neurotoxic, experienced grade 3 or greater neurotoxicity. So there is some suggestion that there's improved tolerability with the addition of ibrutinib to the lysocell. I like it also because you do have some disease control during the production time with continued BTK inhibitor. This is the response rate on the left and the undetectable rate on the right. 63% of the patients achieving a complete remission. 95% was the overall response rate among those patients. No significant difference in terms of the responses between the dose levels. There were 2 dose levels evaluated in terms of the lysocell dose. Most of the patients received the higher dose level, and almost 90% of the 19 patients achieved an undetectable MRD status in blood. So very good activity, particularly in a heavily pretreated relapsed refractory population. And this is the swimmer's curve where you can see most of those patients are continuing in remission following treatment. One thing to point out is the kinetics of expansion of the lysocell. And that was evaluated and summarized here. This is expansion for the combined cohort. And you can see, focusing on the Cmax here, that peak Cmax was 128,000. You can see in the top left box here. That's in comparison to what was seen with the monotherapy cohort, which was about half the Cmax. So I think for me, this suggests is some indication and suggestion that perhaps there is better expansion of the product after it's infused if it's given in combination with ibrutinib compared to monotherapy, shown here. So this slide is a summary slide and summarizes the features from the ASH presentations that I just reviewed. Combined targeted therapy, highly effective. We're seeing very durable remissions in patients off treatment, particularly for venetoclax-based therapy in the frontline setting and in the relapsed setting. Umbralisib is a PI3 kinase that probably will be approved and will be a treatment option, and clearly the outcomes are better than they are with chemoimmunotherapy with that agent. LOXO-305, very well tolerated, very promising agent that will probably be approved in the US and hopefully will be broadly available to our patients. That's extremely well tolerated. And then the CAR-19 work is continuing and will hopefully be published and lead to approval in the near future. More challenging treatment to give, but I think offers a reasonable option for patients, particularly with refractory disease. So with that, I'll thank you for your attention and be happy to take any questions.
Thank you, Dr. William, for your nice talk. And the floor is now open for a few questions. We will start with Dr. Ayman Abu Khamar.
Thank you, Doctor, for this comprehensive talk. My question about the BTK inhibitors. We know that if we started our patient on BTK BTK inhibitors, progression. My question is, if the patient achieved MRD negativity or deep MRD response, could we stop the treatment at a certain point, or at this point if the patient getting MRD negativity? You know, we are using expensive drugs, so the duration of treatment is very important, I think, for the patient.
Yes.
So do you think we could stop it?
Yes, so I think we can. There aren't any studies that have answered that question specifically with BTK inhibitor-based therapy. We have recently initiated 2 trials of BTK plus a CD20 antibody, where we're giving 2 years of fixed duration of BTK, 6 cycles of the CD20 antibody, and patients will be coming off treatment after that 2 years. I think if patients, it's very uncommon for patients, if they get just a BTK inhibitor monotherapy, it's very uncommon for them to achieve an undetectable MRD status. If they do, I think it's fine to get them off treatment when they're undetectable, and then retreating them when they have progressive disease. The only group that I really worry about, and I'm very nervous about coming off treatment, even if they're undetectable, are those with a 17p deletion.
I have a question, Dr. William. You know that in CLL patient, we have overexpression for BCL2 in more than 70% of cases. And 17% of cases, they have deletion of chromosome 70. Do you recommend to start frontline combination BTK inhibitor plus anti-BCL2 as first line?
For the 17p deletion?
With overexpression of knowing that we have CLL patient more than 70% with overexpressed BCL2.
So I like fixed duration treatment, and I think that's where we're moving with all of our treatments. Fixed duration treatment with combination strategies. So I think the answer to your question is yes, I am most enthusiastic about fixed duration BCL2 based treatment in the frontline setting, particularly because I like the idea of getting patients in a deep remission and getting them off treatment. The only group that I really worry about, and they're not very common, they're less than 10%, less than probably 8%, are the 17p deleted first line patients. Those patients, I still am inclined to keep on treatment and will put them on BTK inhibitor-based treatment because I'm worried about them having a shorter progression-free survival and with fixed duration treatment. So that's the only exception is the 17p mutated TP53.
Question,
Any more
please.
questions? Last questions, yes.
Dr. Nabil. Can I ask a question?
Dr. Ahmed?
Yep.
Yes, go ahead. For the sake of time, this is the last question.
I'm Dr. Halahla. Dr. Ahmed, you can ask a question?
محمد بده يحكي.
Please.
محمد سلام احكي.
Go on.
Thank you very much. I want to ask you one question which is concerned me always when we are talking about CLL, which is the MRD testing. Do you think that doing an MRD testing is an important only for prognosis or only also with therapeutic indication? And if so, what is the cutoff number of the MRD that make you thinking of stopping the treatment?
Today, MRD is prognostically helpful. Tomorrow, or in the future, I think it will be used as a treatment endpoint. It's not used, we're not using it as a standard of care treatment endpoint yet. We're working on generating data that supports that strategy. So right now it's predictive of outcomes, and I do evaluate MRD. And with our newer trials, which will be MRD directed treatment, we'll have more data that supports using it as a treatment endpoint. But right now it's more prognostic than anything else.
Thank you very much.
Thank you, Dr. William, for your nice talk. And finally, I will thank HIKMA company for supporting this symposium and see you again.
Thank you.